Hey guys, my name is Kate Scarlata, and I'm going to be talking to you primarily about irritable bowel syndrome, but there's been a lot of requests about small intestinal bacterial overgrowth, which presents with similar symptoms in many people, and then also the low FODMAP diet, which is an elimination three-phase nutritional approach to managing symptoms in irritable bowel syndrome. So I'll close this a little bit. So let me just get started. I know you guys have some questions. I'm just going to do a quick overview. Irritable bowel syndrome impacts about 11% of people globally. This isn't just a condition in which you may experience a little bloating, a little gas, periodic diarrhea. This is a condition in which patients are quite troubled with these symptoms to the tune of a significant quality of life reduction. So there was a study done in the Journal of Clinical Gastroenterology that looked at these patients. It was an international survey. And in this survey, they found that 2,000 individuals, that they were willing to give about 25% of their remaining life for a treatment that would provide symptom relief. So again, this isn't mild GI distress. This is a life-changing, often condition that really has an impact on quality of life. So again, it impacts about 11% globally, more prevalent in women, about a twofold increase in women versus men, and can really impact all age groups. Another important thing is irritable bowel syndrome is diagnosed based on a symptom profile. So the criteria has been reviewed and put out by the Rome Foundation, and we are currently on the Rome 4 criteria, which is something you can look into to see specifically how what needs to be present for this condition to be diagnosed. So, but in general, irritable bowel syndrome is a motility disorder. So patients present with some dysfunction in the way their bowel moves. Additionally, another big cornerstone piece to this is that there's a hypersensitivity found in the intestine. And we know that there's alterations in the microflora that reside in someone with irritable bowel syndrome compared to a healthy control. And more recently, we're learning that the metabolites that the bacteria produce in patients with irritable bowel are also different. What's really interesting to tie into the low FODMAP diet is that you can do some stool profiling and look at these compounds called volatile organic compounds. And by looking at these particular compounds, they're able to detect which patients would be more likely to respond to the low FODMAP diet, which is very good because the low FODMAP diet, as dietitians know, in patients that follow it, it is highly restrictive diet. The other important point I want to say before I grab some questions from you, because there's some really great questions, is that not everyone with irritable bowel syndrome should be recommended to do the low FODMAP diet. There's a few things that I've mentioned. I recently wrote an article for the American Journal of Gastroenterology, and if you follow Twitter, it's my pinned tweet, so you can find it there and access the article. But what I will tell you is that, you know, in my practice, I really believe that if you're concerned that the patient has major food fears, an eating disordered past, just maladaptive eating, you want to be very careful. This is probably not the patient that you want to put on the low FODMAP diet. I would investigate alternative therapies. There's gut-directed hypnotherapy, cognitive behavioral therapy. The Rome Foundation has a fabulous resource list that shows where patients can access a GI dietitian and a GI psychologist. So I recently did a post about sort of it's called the emotional scars of, you know, living with irritable bowel syndrome and SIBO. And in that blog post, you can find both a dietitian registry for the low FODMAP diet if it's indicated, and then also an access registry for GI psychologists, because this is really important. Just the stress of experiencing irritable bowel syndrome symptoms is enough to cause the symptoms. So it kind of is this big vicious cycle, and patients really need the psychological support. The other thing is that about 40% of patients with IBS experience some form of depression and anxiety. And whether that's a cause or effect of the illness really remains to be elucidated. So I just want to get to a couple of the questions. We'll get started because you had some really good ones. One of them was that an individual found that the low FODMAP diet in practice works better for people with irritable bowel syndrome that has a diarrhea predominance versus constipation predominance. And certainly theoretically that makes sense. First of all, the majority of the research in this area for FODMAP diets has looked at IBS diarrhea predominant patients in their studies. The irritable bowel symptoms, well, first of all, FODMAPs are these osmotic, they're very small chain carbohydrates, and they have two major, effects. They are, because they're small, they're osmotic, they can pull water into the gut. The smaller the FODMAP, the more osmotic. So excess fructose is a monosaccharide. It's the smallest of the FODMAP subtypes. It's more likely to pull water into the gut. While the longer FODMAPs, the fructans and galacto-oligosaccharides, which fall under the oligosaccharides or O subtype, those tend to have the more gas fermentative effects. So when we think about using the diet with irritable bowel syndrome with diarrhea, certainly it seems to make sense that this population would do better with the diet because the osmotic effects of extra water in the gut, if we eliminate that with a low FODMAP diet, that population probably will do well. And that's probably is the case. They're probably a little bit more evidence-based, and the diet is probably more effective for that population. Individuals with constipation, however, do find, or in clinical practice and in some of the research that have included this subtype of IBS, they also do well to some degree. It can enhance the constipation because we're eliminating some food sources like prunes and things with sorbitol that would pull water in and are shown, we know, contribute to laxation and can help with constipation. So eliminating those could be a problem, right? That makes sense. But the pain and the bloating are really troublesome symptoms for these patients. And in clinical practice, those two symptoms are drastically reduced. I do find, however, when you're working with irritable bowel syndrome patients, it's really important to note that the diet is a piece of the symptom, is sort of the piece of the treatment. It's not the whole treatment. Often we have to look at other things, whether it's medications, whether it's stress management strategies, whether it's laxatives potentially that are needed, or in a subset of patients with irritable bowel syndrome, they present with a condition called dysnergic defecation. And this is when the normal bowel movement just does not occur because the nerves and the muscles are actually working in opposite directions. And so it doesn't allow for an adequate bowel movement. In those patients, they really do well with physical therapy, a specialized pelvic floor physical therapy. So again, when you're looking and working with these patients, I think it's very important to make note that the diet is often a piece of the treatment, but it may not be the entire treatment for these patients. So to the question about low FODMAP diet with IBS and IBS-D, I agree. I think in practice, I feel very confident that it's going to help a patient that's suitable for the diet with IBS-D or diarrhea predominance. And then with IBS-D, it may help some of the symptoms, but often you have to look at managing some other strategies to help the intestine flowing and moving and clearing stool, which can really contribute to the symptoms. And pay attention to the diagnosis called dysnergic defecation, which I just described, which does occur in a number of patients with constipation. Another question that was brought about from this Facebook Live was, what is the medical nutrition therapy for small intestinal bacterial overgrowth? So first of all, there is no medical nutrition therapy for small intestinal bacterial overgrowth because, unfortunately, this condition has not really been studied looking at diet at all. One of the things, the low FODMAP diet often is recommended for this group, this condition that have small intestinal bacterial overgrowth, because the symptoms are very similar to those found in irritable bowel syndrome. In fact, about 60% of people with small intestinal bacterial overgrowth fit the criteria for IBS. When they've looked at testing for small intestinal bacterial overgrowth, which is basically an overgrowth of bacteria in the small intestine, bacteria should not reside there in great numbers. So when that happens, you know, the bacteria can interface with food before it even gets digested. I actually have experienced that condition. You're at risk if you do not have an ileocecal valve, and unfortunately mine was resected due to a strangulated bowel. You may see a resected ileocecal valve also in individuals with Crohn's disease if they've done resection of the small bowel and the ileum. But there are other risk factors for small intestinal bacterial overgrowth, from hypothyroidism to diabetes, pancreatic insufficiency. This is being tested primarily through breath test, which really is got some lack of sensitivity and specificity. The testing is not perfect. And if you look at the data, looking at individuals with IBS that have positive SIBO testing, it does really vary depending on whether they had lactulose used during the breath test or glucose or small bowel culture, where they actually went down and cultured the bacteria. So there is, the testing isn't perfect. I do believe it's a true condition. A lot of patients benefit from treatment. The primary treatment for this condition is to use a non-absorbable antibiotic called rifaximin, and then also really assessing, if possible, is there an underlying condition that could be corrected? For instance, in pancreatic insufficiency, could we add some pancreatic enzymes to help the digestion? Pancreatic secretions, as well as bile, are both antimicrobials in the small intestine. So if you don't have a good functioning gallbladder, or your small intestine or your pancreas is not secreting enough pancreatic secretions, that is a risk factor for developing SIBO as well. So again, no medical nutrition therapy for SIBO. However, because a bulk of these patients do fit the criteria for irritable bowel syndrome, we do find in clinical practice that the low FODMAP diet is beneficial for these patients. There is a lot of sites online that encourage highly restrictive diets for these patients with, again, zero evidence. They're a group that has highly maladaptive eating because eating food exacerbates their symptoms significantly. And they really need a multi-prong approach to help them get to sort of that other side of feeling well, like I do. And that often will take understanding what diet works for them, what antibiotics they need, and if there's a correctable reason for the reason they got small intestinal bacteria, correct that correctable reason. I have talked to numerous researchers about getting studies underway for this condition because we need some evidence-based. Patients really deserve to know what works and what doesn't. Another question that came across yesterday was, again, on small intestinal bacterial overgrowth. And this was a question regarding using herbal therapies for small intestinal bacterial overgrowth. And there is one research paper available, and I did note it in the notes from yesterday, my little teaser video that I put on. So I attached the article to that area if you want to find it. But this is a study done at Johns Hopkins where they compared rifaximin to two different herbal therapies. One was a Metagenics combo product and one was a Biotics product. Two different herbals that they used for about a month compared to 1,200 milligrams of rifaximin. It's important to note that the dose of rifaximin used currently for SIBO treatment is higher than the 1,200 milligrams. So we're kind of comparing a therapy that's might not even be effective to compare to the herbals, but it did show that the herbals to 1,200 milligrams of rifaximin had similar efficacy rates. I struggle a little bit with using herbals just because they are unregulated, and I think that's very important that patients understand that many of these products are not third-party tested, and you're, buyer beware, you don't really know what you're utilizing. I also wonder if using herbal antibiotics is out of scope of our practice, right? So how far is it suitable for dietitians to start mucking around with the gut microbiome to that degree? It's a fine line because many of us recommend probiotics and prebiotic-rich foods, but the herbals crosses the line a little bit for me personally. I have worked with some gastroenterologists that do utilize them, and I feel better that they're the ones prescribing them than myself. But again, that's, it's a scope of practice issue that I don't feel it's personally my job. So does that mean that herbals are evidence-based? Well, there's one study, so I don't feel that that's enough to say hands down herbals are as effective as rifaximin. Are they being utilized by a number of naturopaths and various practitioners across the country? Absolutely, but I think we have to stick to evidence-based medicine and work within the confines and at least be very clear with that information with our patients. Okay, so the other question I had was about SIBO too. So this is kind of a hot topic and area, and one that of course is near and dear to me. So SIBO can present with a number of different gases. So small intestinal bacterial overgrowth is measured either using glucose or lactulose in general. The patient ingests those carbohydrates, and then the substrate gets into the small intestine. The bacteria that reside there either produce methane or hydrogen. They might produce hydrogen sulfide gas as well. And that gas, the hydrogen and the methane, will go through the bloodstream. A proportion of it ends up in the lungs, and the patient breathes that out. So that gas is from bacteria. And there is a consensus that suggests that an increase of hydrogen greater than the baseline level that they received during the initial breath testing, if it rises above 20 parts per million, that would be a positive SIBO test. And there is a consensus that says anything greater than 10 parts per million for methane is positive anytime during the test. But still globally, there's questions about the validity of the testing. Are these numbers the proper cutoff? So there's still some controversy around that. But in general, those are the numbers that I tend to stick with. If someone has hydrogen sulfide gas, there's a new machine just developed and just used in the research setting that's able to check for hydrogen sulfide gas. However, in the clinical space, we don't have that. Someone that might be positive for hydrogen sulfide gas may present with a flat line breath test. So when you look at the breath test results, it says 0, 0 for hydrogen and methane the entire time. That's kind of unusual, and that might be that the patient actually is making hydrogen sulfide gas, because all of the hydrogen is going to make the hydrogen sulfide gas, and actually hydrogen sulfide just doesn't get picked up on that particular breath test. I don't want to get into the semantics of it, but Mark Pimentel's group's looking at hydrogen sulfide. It's associated with fatigue and diarrhea. They're treating it right now with rifaximin, but there's a lot of research that needs to be done to really look at that particular type of small intestinal bacterial overgrowth. What we have found in clinical practice is that hydrogen sulfide SIBO does very well with rifaximin treatment, while methane tends to do a little better with a dual therapy. This is not evidence-based. There is one study that shows using rifaximin and neomycin did have better efficacy for clearing methane gas. And there hasn't been anything done since, but neomycin's been black boxed by the FDA, so it's not a drug that's used commonly. And a lot of the physicians that I've worked with here in Boston will do a combination of rifaximin and flagyl, a little bit off label. And those patients do better. There needs to be research though. And again, that's not what I do, but just so you know that patients know that they read a lot and they will ask you about dual therapy for methane. And all I can tell you is my clinical experience does show that it does seem to be better. Okay, questions? No more questions. Okay, let's see. Oh, okay, good. There is a question there. So as far as resources for small intestinal bacterial overgrowth, that's a really good question because there's a lot of pseudoscience out there. I honestly, if you're a dietitian, I recommend that you scour the literature. I do have a SIBO handout that I sell on my website, and I also have a number of SIBO articles for free on my blog, so you can just query Kate Scarlata SIBO, S-I-B-O, and I have provided a lot of different references and information. There is, I believe, gutmicrobes.org is another website that you can find some resources on small intestinal bacterial overgrowth as well. And then I would follow Mark Pimentel's work. He's at Cedars-Sinai, and he's really leading the charge globally in this area, really connecting the dots between microbial alterations as well as in how that impacts IBS and IBS symptoms. So a couple of the resources, why don't I get started a little bit more with the low FODMAP diet, since everyone knows that's my area. So the low FODMAP diet is a 3-phase nutritional approach. I really look at the FODMAP approach as a really great framework. A lot of patients that actually come to me in my practice are often eating 6 to 10 foods, and the FODMAP diet has provided a fabulous framework for me to expand them. Looking at some of the foods that are low in FODMAPs, they'll be the first ones that I add back gently because they often tolerate them better. So my practice tends to be a little bit different from that vantage point. Patients are come to me highly restricted, which is really sad for me, and I want to expand their diet. And I think as dietitians in this crazy food environment that we are in, there's so much fear mongering, crazy diet recommendations, that we as professionals really need to help our patients sort out how to eat properly, to not put so much emphasis on eating as a symptom, guilt for the cause of everything that's going on with them, to help them decrease the obsession with every nutrient, the orthorexia. We have to look at ARFID. There's a avoidance restrictive eating disorder that IBS patients are very primed for, and this is when food causes symptoms, you develop fear towards food. So first and foremost, we really want to make sure that we select people that are appropriate from an emotional standpoint and really think they're suitable for the low FODMAP diet. But it's a 3-phased diet to back up. The elimination phase, basically we're removing high FODMAP foods for about 2 to 4 weeks to settle the gut down. And then at that point, we bring the patient back into clinic and we start the reintroduction process. So the reintroduction process is really to tease out what FODMAP subtypes the patients may be sensitive to. So we're not seeing if they can add an apple back in day 1. We're really looking at, is lactose a trigger for them? Is excess fructose a trigger for them? Or fructans a trigger for them? So we're going to go through, keep them on the low FODMAP diet, and then if we were going to test their tolerance to lactose, I would start with maybe a half a cup of milk day 1. The next day they would keep on their low FODMAP diet, add a cup of milk. The next day they might have a cup and a half of milk, and we would assess at that point how they're feeling. If they pass the challenge, we remove the lactose from the diet still. We start with a fresh low FODMAP diet and then challenge excess fructose. When we're challenging a FODMAP subtype, we want to make sure that we're utilizing a food that only has that FODMAP subtype. So an example for excess fructose would be mango or honey. The Monash team has upped the honey so that patients can have a little bit on the elimination phase. But if I was doing a challenge for the for honey, I might start with a tablespoon and see how they do and up it incrementally. And the patient you just have to remind the patient, we're really just testing your tolerance to excess fructose and see how your body does with that. Even if they weren't a big honey person and they weren't a really big mango person, we would still try to choose the food that only has that subtype. Again, we're testing their tolerance to the subtype, not a food per se. And then we would go through the fructans. The fructan reintroduction involves, we do a wheat, onion, and garlic challenge. I'll show you my book. I think we did a really fabulous job in the low FODMAP diet step-by-step book. It's like trying to figure out which way to put this. So this book is, pretty, it's been up for about a year, but I feel like the reintroduction process is really drilled down in this book if you're looking for a reference. And it just basically, there isn't a standardized reintroduction process. So patients, dietitians use a little bit of art and science to do this, but I feel like I've been reintroducing very successfully and might be a good resource for you. After the reintroduction phase becomes the personalization phase. So this is the phase in which when the patient finds that they can do lactose, they can maybe do sorbitol, we would start adding some of those foods back onto their daily plate to really liberalize their diet. And then very, very important, tolerance to FODMAPs can change day to day, time to time, stress, being constipated, a number of factors can affect GI symptoms. So it's important that patients keep trying to liberalize their diet as they gain confidence. They might have failed the wheat challenge 6 months ago. It might be time to try it again and see if they tolerate wheat better now that things are even settled down even more. So I think that can be very, very helpful. I also think it's really important as dietitians that we don't just teach someone a low FODMAP diet approach. We really want to maximize their nutrition and think about just nourishing your body for good health. This is not to put pressure on them about not eating a cookie or I'm all about sweets, so that's not me. But one of my handouts that's free is this Nourish Bowl handout. This is on my website under katescarlata.com. There's a number of free resources. But in this handout, I kind of list all the low FODMAP foods and also break it down to the fruits, the healthy fats, the vegetables, the protein, the grains. So really want to get my patients to be eating a very well-balanced diet. If they're eating a ton of vegetables, even if they're low FODMAP, it just could be too much fiber for their body, and that could be a trigger in itself. So when you balance the plate out a little nice evenly, I find that patients, I tell them balanced plate, balanced gut, and it tends to work really well for most patients as well. I also have another free resource, and this is just a FODMAPs 101 handout. Again, this is on katescarlata.com under the FODMAP resource tab, and this just talks just generally about the FODMAP diet, what it is, what are some food sources, how FODMAPs may feel in the gut. There's a water balloon and a gas, a hot air balloon, just visuals to make them think about the gas and that osmotic effect for them to kind of understand it in a different way. I also have these what we call grab and go passes, and this is for the chef and also just general information. So this is something a patient could bring to a restaurant. The primary FODMAPs at a restaurant are really wheat, garlic, and onion. Obviously other things might slip in and other things, but usually they're called out on the menu. So this can help them provide a little information sheet very indiscriminately when they're dining out. So there are plenty of free resources on my website that I'm more than happy for you to use them with patients. I want them to have good resources to make the diet as easy as possible. But I do really caution you to be very selective when you choose a patient for the low FODMAP diet, because we do not want to encourage more maladaptive eating and contribute to more disordered eating. We're really in an environment right now that I think is really ripe for that. The other thing is, just trying to incorporate intuitive eating models, having patients really identify and be in tune to their body on what really does cause symptoms for them, and making peace with food and letting go of food fears and addressing that. One of the things that I do in my practice is I have a digestive health and history form, and on that form I have them fill out a number of different symptoms that they may be incurring. I also